In this online module, we'll discuss airway management. The course is broken up into several smaller pieces so it's manageable online. Each section will then have a short quiz with a final exam at the end of all of the sections. Participants must complete each quiz and the final exam in order to get credit for the entire course. Our course objectives today: we're going to review some airway anatomy and talk about some of the functional issues that go on with that. We'll review airway and pulmonary pathologies, specifically as it looks at airway and airway management problems. We'll discuss airway decision-making process, and then we'll outline the aspects for quality improvement that are important here in Kalamazoo County. The first part is a review of the anatomy. So we'll start with the upper airway. These are things that certainly we would expect all the medics to understand and be able to locate on the diagram. Of course, the mouth and nose, the oral and nasal pharynx just behind it, those groups come together, and the glottic opening, an important part of this airway. As we look into devices, that's going to be the key focus for our supraglottic airways and where they engage some of the structures and ensuring that we form a good seat so we can get proper ventilations. Of course, that includes, as you come through the glottic opening, the larynx, and down farther, the trachea. This diagram shows the pharynx in what we call an open view. So the pharynx has been hinged to help reveal the structures. It's positioned as though it were looking into the screen. If you look to the bottom of the diagram, you can see the trachea in the front and the esophagus towards the rear, just as you'd be sitting in your seat looking at this. The anatomy's been hinged along this nasal-oropharynx line. So above it, the nasal pharynx, structures of the nasal pharynx, you can see the nasal septum towards the top, the tonsils there, and the soft palate. When you hit the red line, you go below that, you can see the roof of the tongue, and we move down the glottic opening, or what they call the laryngeal inlet, the laryngopharynx, and as you move towards the bottom, of course, the esophagus. So what we really want to focus on here is a laryngeal framework. Typical supraglottic airways, such as the I-gel or the LMA mask, seat right over that laryngeal inlet. Other subglottic airways, such as the combi tube or the king, work by isolating that laryngeal opening with inflatable cuffs, both proximal and distal to that inlet. One of the advantages of having the airway seated in that position is that we now have control of the esophagus. We can plug it, we can suction it, removing pressure in the stomach context, and hopefully reduce the amount of vomiting and the amount of fluids that end up entering into the trachea. This will potentially decrease the amount of pneumonias that patients get once they're admitted into the hospital. So look at the lower airway now. Again, the medic should be able to locate all the following structures. Of course, the trachea at the top of that respiratory tree, the cartilaginous rings that help support it, becomes very important when we inflate cuffs to try to maintain the airway on things like endotracheal tubes or potentially a combi tube that occasionally does get placed into the trachea. As we continue down the trachea, we meet the carina. That's, of course, where the left and right main stem bronchi branch off. It's important to remember how these structures are positioned in space. So we remember that when we use endotracheal tubes, if we go too deep, potentially end up in that right main stem bronchi, thereby isolating half of the pulmonary system and definitely reducing our ability to ventilate and perfuse our patients. Move down the tree into the lobar bronchi and into the bronchioles. The airways continue to get smaller and smaller and smaller. Eventually move into the alveolar ducts and, of course, the alveoli, where the actual gas exchange happens. A quick note about the alveoli and that gas exchange. Of course, oxygen and carbon dioxide are exchanged across a semipermeable membrane. A couple things we need to think about as we deal with our pulmonary patients. The exchange rate can be affected by a couple of things. It would certainly be affected by the partial pressure of each individual gas, and that gas's rate, of course, is independent of other gases that might be in there. The importance of this is as you start to raise the percentage of oxygen through supplemental oxygen, it means it's going to diffuse faster across the airway. That's important to try to bring pulse oxes up. The alveoli surface area has a lot to do with the amount of gas that can be exchanged. When the alveoli collapse, there's not as much surface area available. We can't exchange as much oxygen and carbon dioxide back and forth. The final thing that affects that is distance across the membrane. As the alveoli stretch out, they actually become slightly thinner, increases the amount of gas that can be exchanged across it. We'll notice that with that surface area, we use things like CPAP and give a continuous positive airway pressure. We can actually hold those alveoli open, and by doing so allow the gas longer time to exchange back and forth. Doing so, we can drive O2 and CO2 levels to appropriate numbers. The final note on the alveoli is the elastic properties of those alveoli help force the air out during expiration. Of course, this requires extra effort for inspiration to expand them back out, and that, again, is where CPAP can help out. So we'll talk about a couple pathologies before we move on. And when we look at these pathologies, we'll talk about airway and respiratory, but focus on how that affects our airway management. We'll talk about ventilation, perfusion, the VQ ratio, and potential VQ mismatch. So ventilation, of course, is the amount of air that can be moved in and out of the alveoli. This doesn't take into consideration any air that's left up in the dead spaces of the upper and lower airways. We're really looking at what can we do at the alveoli level to move fresh air in and out. Perfusion is then the gas exchange across the alveolar membrane. As VQ mismatch occurs when one of those is disrupted, either by disease or some sort of trauma. Some of the ways that can happen in the lung include shunting or dead spacing. Shunting is where we block the airway, either mechanically through a foreign body or potentially through disease processes, such as asthma. We get perfusion across the membrane without ventilation. The blood's still moving by, but no air is exchanging. Dead spacing is kind of the opposite effect. The airways are open and the air is moving, but we're not perfusing across the membrane. The blood, for some reason, is stopped, and that area of the lung then becomes a dead space. This is what we commonly see in people with pulmonary embolisms. They complain of dyspnea, sometimes quite profound, and their lung sounds are clear and equal bilaterally. Of course, the overall goal is to improve that VQ ratio and reduce the VQ mismatch. Again, going back to the focus of this unit is the upper airway. Most of the things that we're going to concentrate on are some foreign body obstructions, potentially disease processes like asthma, or the fact that for some reason the patient is not breathing, such as they're in cardiac arrest. So airway pathologies that we can look at, both upper and lower airways. Upper airways, certainly trauma to the head, the face, trauma to the throat, neck structures, damage to the jaw and other structures in the mouth, make it very difficult to both gain access or to find our landmarks if we're trying to do direct visualization and endotracheal intubation. Vomit is a big one that we have to deal with in cardiac arrests. Also the tongue itself, being in the upper airway. If a patient has a particularly large tongue, it's hard to displace, either to get visualization for an endotracheal tube, or it could actually affect the way we put in different supraglottic airways. Foreign body obstruction can cause problems seating the airway or even getting the airway put into place. This is especially problematic with some of the supraglottic airways, which are meant to be blind insertions. Disease processes can affect the airway, abnormal growths, cysts or abscess, peritonsillar cysts can become quite large, actually cause difficulty in breathing for the patient. If we were to have to place a device around those, sometimes the amount of room left for the airway and the airway procedure can be quite diminished. And of course, different congenital problems. Structures that are not where we think they're going to be when we take a view, especially for endotracheal intubation, our landmarks might be off or missing, or potentially structures of the pharyngeal opening might not be in place to properly seat things like the I-gel airway. Lower airway problems, again, more trauma to the chest, foreign body obstructions, disease processes such as bronchospasms can affect the airways. Asthma itself, again, constricting the airway down. This will require higher airway pressures then to push ventilations down into the alveoli. Sometimes those airway pressures become quite extreme and supraglottic airways won't always hold. In asthma patients that go into respiratory arrest, a lot of times we find that endotracheal tube is probably the best choice for these patients, as we can push it a little higher airway pressures and help to reduce our VQ mismatch. COPDs are also a problem, a pathology that we need to deal with in the lower airways. As we, again, increase pressures, we can cause spontaneous pneumothorax, which can become spontaneous tension pneumothorax and increase pathologies for the patient. This is probably pretty true in cardiac arrest patients where they have a COPD history, and we need to be especially aware of that when we look at our H's and T's and consider a patient who may potentially be in some sort of a PEA and doesn't respond to initial fluid therapy or pressor therapies. And that concludes the first section of this online module. If you return to the main portion of the online classroom, you should find a short quiz. And once you complete that quiz, you should be able to move on to the next portion of this module.